Well, it's been a fun few weeks talking about women's sexuality, hormones, and clearly, Charlotte's been having a lot of fun without me here on set. And as you can tell, Charlotte's not here with us today, and it's my turn to talk about some men's issues when it comes to hormones and sex. Often men don't either realize that their testosterone is low or don't really want to say or do anything about it. But I can tell you it's a game changer, not only in the bedroom, but all around vitality. And as Dr. Holmes says, zest for life. My guest today is Dr. Alan Holmes from Biosymmetry in Wilmington, North Carolina. Dr. Alan Holmes is a board-certified emergency medicine physician with over 20 years of experience in patient care, seeing and treating medical problems at their worst, birthed this desire in him to want to prevent disease and optimize health rather than just react to it when it came into the emergency room. He is certified in advanced bioidentical hormone therapy via WorldLink Medical. In addition, he is board certified in obesity medicine. Dr. Holmes' other interests include peptide therapy, PRP therapy, and other cutting-edge modalities to help his patients improve their quality of life and achieve vitality. Dr. Allen lives in Wilmington with his wife, Jen, and their 3 kids. In today's conversation, we get into all aspects of testosterone therapy, the risks, the myths, and cover all of the good options for testosterone therapy. Pay close attention to the studies that Dr. Allen mentions about safety and efficacy of hormone replacement for men, and in the end, the role of estrogen and how it plays out in our overall health and wellness. This much and more are up next on this episode of Master Your Marriage. So, Dr. Alan Holmes, he's here to talk about, well, his career, but more specifically, we're going to talk about male hormones and how that affects the male species, because we already had some topics on female hormones. But first, Alan, I have this question. You spent how many years in emergency medicine?
Nearly 20.
20 years in emergency medicine. And what caused the change? Like, why did you sort of switch?
Yeah, I honestly, I felt like I was on the wrong side of the problem. And in the ER, I would frequently just, handle situations that I knew that had it been an intervention years before, maybe this wouldn't have happened. Maybe this person wouldn't have fallen down, or maybe this person wouldn't have had heart issues, or whatever the situation ended up being. And more, I just kind of became passionate about what happens on the preventative side. How can some of these things that are happening be prevented in terms of not offering sick care, but offering health care?
Yeah, that's. I mean, even in my side. So as a physical therapist, and seeing people that just, you're just like, man, if we could have intervened sooner, and that brings us to a whole nother conversation about health and wellness that maybe we could probably dig into later, because I have a lot to say about that, I think, as you do as well. All right. So when it comes to this hormone discussion, let's just briefly outline the changes between women, because that's the one the most popular one, I guess. That's the one that's in the news, is one we hear about the most. So just changes that women have in hormones. And then let's talk about some of the changes that happen to men. And this probably the more relevant part of that conversation is as we age.
Sure. Yeah, with women, it's definitely more classically when we talk about menopause or perimenopause, and then women entering that time when the ovaries literally just stop producing hormones, and then they're called menopause, and then it goes from there. And there's not an exact kind of process in men like that, where there's just this cutoff one day where the hormones just stop. But over time, as we age, the hormone, particularly testosterone, when we think about men, begins to decline. And honestly, that starts happening earlier and earlier. I meet more and more men in their 30s, 40s, where the symptoms are already starting, and you check their levels and they're already beginning to decline much lower than what you would expect them to be.
Yeah. And so the interesting part is, that sort of brings up another topic, because when we look at just total free testosterone or bound testosterone in males over the past number of 10 years, and the total levels have either, based on the literature that I researched, been decreasing, or we're just getting better at sensing it. I don't know what that is, but if, when you listen to the media, it just says that men now are certainly lower in their total testosterone availability in the year 2024 than they were in the 2016, 2005. I don't know and I don't know if there's any comment to that, but
yeah, I think that, from one perspective, there's not any literature, there's not a number that says, a testosterone level of X is good or a testosterone level of X is dangerous. That literature actually doesn't exist. But what we do know for sure is that because of declining health, because of obesity and other related factors, the levels are beginning to drop. And what is sadly, in my opinion, happening is that the normal ranges are being adjusted not based on what would be optimal, but is based on what the population looks like. In 2017, they changed the LabCorp changed their numbers where what used to be normal testosterone level was 400. They reduced it to 240 on the low end, and that was based on just looking at a population of couple thousand men and realizing that the numbers were lower. And so they just literally changed the normal range to fit the population.
And so what does that mean I mean, I have a story about that, but I mean, what does that mean for men when it comes to healthcare and this version of low testosterone? They go in to see their doctor and their doctor says 250, you're fine.
Yeah, exactly. They go to see their doctor and they're tired and their libido's gone and their sexual performance is gone, their vitality's gone, and they know that something's wrong. And so, the doctor maybe tests their testosterone, maybe doesn't. But if he tests it and it lands in that normal range, they're told, no, you're okay. Maybe here's an antidepressant or here's a pill. Even though clearly they have symptoms that are classic for low testosterone.
Yeah. And we're going to dig into that a lot. So I want to qualify the terms that fall out there. So first we have kind of the one that maybe we see a lot. It's called menopause, which really doesn't exist. And then we have one called, I had to look it up over here because it left me in my head. Andropause, which is not a very good descriptor of what that is because that's a clear medical condition that has some indication. And then we have low T and then we have LOH. So maybe just adjust those for me so we can talk about what we're talking about. And if low T is really the term, then low T is the term.
Yeah. I mean, I think, probably maybe that one fits the best. I mean, andropause would kind of, I think, come along to mimic menopause, even though those are kind of two different processes where in women, there's literally a day that there's just the production stops. And that doesn't exactly happen in men. In men, it's more kind of a slow decline over time. But I think low T is in terms of terminology, a good term to use.
So let's talk about, and you alluded to those just a little bit, about the, men feel fatigued, they feel low energy. What other symptoms? I mean, libido is one of them, of course, but what are the other symptoms that they might maybe see, or not even necessarily know is happening to them? Maybe people are listening, they're like, oh yeah, these are some things as I age, I'm starting to notice these types of changes. What would this be?
Yeah. I mean, one certainly would be, your performance in the gym. Are you making gains like you used to? And that's probably not the case. You're not as strong as you used to be. And then there's simply the motivation to even go to the gym. I hear a lot of guys say, I used to go to gym 3-4 days a week and really enjoyed it. And now I can't even get myself to drive to the gym is a classic story that I hear for sure. And then that kind of spills over into kind of just general motivation, what I call sort of zest for life, to go out and try new things, to start a new business, to expand, to grow. And those things begin to just decline.
Yeah. So we assume somebody, and for those that are listening, they say, okay, let's, let me think about this. And do you think that it's really the guys, or in your experience, so we're just going to go with your experience, do we feel like it's guys are realizing that there's a problem? Or do you think how much of it is a component of maybe their spouse saying like, hey, you don't have as much vitality or zest for life as you used to, and maybe sort of shepherding them into like, let's do something about this? Because guys don't really want to talk about it, do they?
Very often not. And they know that something's going on. They know it's not like it used to be or even how they want it to be. And they think a lot of them just don't know there is an answer or there is an alternative, that this is just a process of like, I'm getting older. And then sometimes they just, as guys, like, we're fixers. We don't ever want to claim that we need to be fixed.
Absolutely. Yeah.
So we don't want to claim that there's a problem. We just kind of power through as best we can. So a lot of my patients actually come from, the spouse ends up being, my patient first. And then they're like, I've got to get my husband in here. And then that's kind of the natural progression. Although I will say that the more that, terms like low T are talked about on, social media and these types of things, more and more guys do begin to come on their own because they realize that they're not the only one.
Yeah. And this can be a conversation, with my, before I started learning about this whole topic and even working on testosterone supplementation for myself, I had heard some of my friends talking about it and some positive, some negative, some like it doesn't work and it does work. And I think that there's a very interesting balance when it comes to finding what works, what doesn't work when it comes to this. And so we'll go back a number of years for me in my journey, and I'll talk about it, and then I'll probably watch your face as you just go like, "Oh no, how is that happening?" So I think I realized that something was going on, and I just was relatively low energy, and there was a lot of changes that were happening, I think, through my 50s. And so, we found a clinic and they said, oh yeah, your testosterone is low. And I don't think it was down to 250, but it was low. But I also had a lot of other concomitant medical issues at the time. My BMI I had to do the number over 35, which is not great. I had undiagnosed sleep apnea, which meant really I was snoring a lot at night. So I was tired because I wasn't getting enough sleep. I had borderline hypertension. And what happens when you're not sleeping is then you start supplementing with caffeine so that you can have the energy to sort of push through the day. And so I was running in this cycle. And then I went from being heavy, certainly obese in that category, to picking up like another 10 or 15 pounds, just like over a week and a half, it seemed, but it was probably over a couple of weeks. And so it was like, oh, well, maybe testosterone is going to solve my problem. And they were more than happy to, it's like, oh yeah, boom. And, I ended up getting testosterone. And so I think I had more energy, but it worsened everything on the other side of the equation. And I remember being at rounds at the hospital, and they presented a case on a 52-year-old male who was on testosterone supplementation and had active sleep apnea, and he had a stroke. He had a CVA. And I realized that nobody was checking my blood work. Nobody was doing anything on the backside. They just put pellets in and just said, oh, you feel better? Great. I mean, certainly libido was up because that's an amazing side effect, right? So take that patient example and start to tell me like all of the warning signs that you that you might have been concerned about with me, this person coming into your clinic and then receiving testosterone therapy. What would be some of the things that I really feel like we need to track in order to make this a safe intervention?
Yeah, I think, if, as they say, if the tool you have is a hammer, then everything is a nail. And so if you go to a testosterone clinic, then indeed that's going to be the answer, because that's the answer they have for you. And I think this is one of the bad things that happen with testosterone with all these clinics that are around, is that it's like a panacea. It's the end all be all of everything, but nothing beats good nutrition, exercise, sleep. Like those are like the foundational blocks of all of it. And you can run your testosterone levels as high as you want. You're still not going to feel good if you don't have those other pieces in place. I heard a guy say once that testosterone rewards effort, in the sense of, yes, if you are doing all the other things, it's going to help enhance the results of the hard work, of the eating the right foods, of getting the good sleep, of exercising, and that sort of thing. And so if you put testosterone into a man and you don't adjust for any of those other things, then you're not going to get good results. On the flip side, sometimes testosterone gets blamed for bad outcomes. and what I mean by that is, in that scenario that you gave, was it really the testosterone that caused the stroke? Or was it that he had sleep apnea and obesity and he was a setup for a stroke anyway because of insulin resistance or blood pressure, whatever else he had going on? Um, when you look at the studies on testosterone interventions, there are very few that show bad outcomes. And those are typically come from more the weightlifting world, where they're using just horse doses of testosterone, far beyond what, what I would call optimized or responsible use of testosterone would be. That's what a lot of the literature shows, for sure. That it's actually a very, very safe intervention in and of itself.
Yeah, and I love your take on that, because I think that with anything, and I will say that I used that, that case study of that guy, and I didn't necessarily agree that the testosterone caused a problem. I mean, there could have been some, elevated hematocrit, but I mean, what happens when they present things like that? And that the case wasn't necessarily that with testosterone caused it; it was the fact that it was a neuro thing, but it became the catalyst for me to start my journey of becoming a healthier person for not only my family, but for me. So, it was a nice little wake up call. I'm like, holy cow, I have to do something. I can't, I'm in the healthcare field. I know better. And so I made some drastic adjustments in order to make that work. But I love that the testosterone is the catalyst to help things get better, because now, and I work with testosterone supplementation now, and I like the fact that I can see more energy and more gains in the gym, and it makes me feel stronger. It makes me feel better. So there's all those things. So what are some of the less? That was a drastic side effect, and I would say that's less than 1%. The number's got to have a couple of zeros in front of it after the decimal point for any of those, bad outcomes, and you have to add everything else. What are some of the side effects sometimes of testosterone supplementation that we might see? And again, I say the literature would show these side effects as coming from the horse dose testosterone world, but like acne or something like that. What's going on with those guys?
Yeah, so certainly, one of the more common ones is hair loss. In the studies, that happens to people that were already prone to hair loss. In other words, they were already going to have kind of recession of their hairline. And if they go on testosterone, that's going to get a bit worse. Acne is a common one, both on the face as well as what they call back acne, which is probably actually more of a folliculitis than a true acne, is a common one as well. I think a really important one, particularly for younger guys that would be considering testosterone, is that it does make you infertile, because you're shutting down the axis that produces sperm in the testicles. And that may or may not be, a long-term, permanent issue. And so it's one of those things that if you're thinking that you want to have kids, then you should think really hard and have a long discussion with your provider about whether now is the time for testosterone replacement.
Yeah, I mean, and that sort of begs the next maybe medical question when it comes to younger men who are still in their I want to have children phase of their life. I mean, maybe it's a different problem that is really driving their low testosterone that might need a different medical intervention instead of just adding testosterone to the backside of the equation. Because younger men not necessarily would have a lower testosterone. I mean, and it happens, and we're seeing it more and more. But I agree with you. Does this tend to be an older male population for testosterone supplementation for you? I'm sure you see all types.
Yeah, I do. I think kind of late 40s, 50s is probably kind of like the peak of it. And then certainly there's patients into their 60s and 70s as well. I do have a significant population of guys in their 30s, and a lot of that has to do with just environmental changes, what they call endocrine disruptors, the plastics in our food, and all that sort of thing. It absolutely has an effect for sure. The military population, it's very, very common in the military population. For guys that have low testosterone, and in the exact cause of that is I'm not sure anybody exactly knows. Certainly, I'm sure it has to do with kind of just stress and the degrees of training and that sort of thing.
Yeah, I think there's probably a whole conversation to be had about teratogens and environmental concerns when it comes to testosterone. As we age, man, we tend to have, and not tend to have, because I know that the studies will show that anybody that's in their 90s is going to have an enlarged prostate. It's not a matter of if, it's a matter of when. Tell me the effects on of testosterone supplementation on prostate. I know that's a concern for some.
Sure. And this is another one of those things that oftentimes in medicine, something gets said, decades ago, and it just remains to be true, even though we know it's not.
Yeah, absolutely.
The concern around prostate cancer actually came out from a study that was done in 1941, where a guy named Huggins did a study and essentially said that testosterone causes prostate cancer. And that was actually based on 3 guys that got testosterone injections for 2 weeks. They only reported the results of 2 of the guys, and one of the guys had actually been castrated. And so the whole study that said that testosterone causes prostate cancer was about one person, one single man. And that narrative has lasted 80 years at this point. A guy named Morgenthaler, who's a urologist from Harvard, has done a lot of research on testosterone and prostate cancer. And has actually in his studies has found quite the opposite to be true, that low testosterone actually puts you at greater risk of prostate cancer than receiving testosterone.
Yeah, and I love that. And for our listeners, I want to point out, when we make medical decisions based on a body of literature, there's the gold standard when it comes to making a decision based on what the literature says is a thing called a randomized clinical control trial, which means lots of individuals. It has to have a lot of power, and power means number of subjects in the study. Maybe even a better review of that would be combining multiple sources of literature into one thing called the Cochrane Review. And then that would be multiple studies with hundreds and hundreds of people. And so for us to base a medical decision on what we call an N, the N number is the number of patients in the study, an N of 1. And there's a couple of things that still are fairly pervasive. And this is one of those. That's why I wanted to bring that up. There's really no direct link with testosterone supplementation and prostate cancer. It's actually not a thing. And I set you up for that one because I knew that's where that was going. So I would say and so we'll use Robert as an N of 1. In my experience, the risks of testosterone supplementation are increased libido, better mood. I have better performance in the gym. Let me see, decreased trunk mass. So I tend to carry a little less body fat around the middle. I don't know. Those seem to be the risks for me, other than, and having your blood work done. If we're on testosterone supplementation, how often should we have our levels checked just to see how it goes? And again, remember, I'm coming from someone who had I went into just a testosterone place and they just, put pellets in and forgot about me until it was time for the pellets to go in again. What types of things should be monitoring? Because if it's pellets, they're going to wear out. What are some of the other pathways? I guess maybe we should switch and talk about the pathways and then how those are monitored and utilized.
Sure. Yeah. So definitely pellets is an option. And, there's typically every 3 or 4 months, depending on how one metabolizes those. The other 2 primary ones are injections and creams. And those, if done consistently, actually can provide more stable levels than pellets would. So pellets are more kind of like you put them in, they rise to their level, and then they kind of, train back down over a period of months. Whereas creams or injections can stay pretty consistent, and they kind of create just a bit of a little small sine wave, so to speak. So with creams or with injections, a lot of times what I'll do is I'll start someone, and everybody's dose is different. So you have to kind of find their dose. So we start at a dose, and then we check the labs in 4 to 6 weeks. And where did the numbers go? But more importantly than that is, how are you feeling? Meaning, the therapy should not be based on the numbers. The therapy should be based on, are we getting results from the intervention that we made? And so a lot of times we all get hung up on numbers like, oh, I need my testosterone level to be X. Well, as I said in the beginning, that study doesn't actually exist on testosterone level of X means anything. Because I have some men, and I base everything on the free testosterone because that's what's actually unbound and goes into the cells to do something. I have some men that feel excellent with a free testosterone level of 22. I have other men that have a free testosterone level of 35. Everybody's level is different as far as where they need to be. And if we're not having adverse side effects, then the level itself is not dangerous. And we go to whatever dose and level they need to achieve the results we want to achieve.
Yeah, and I like that. And so when we look at the three, there's actually a fourth one, but the literature shows that that's not well tolerated. So there's a patch, a testosterone patch, but in the literature, there's also a what one?
There's also an oral form that I'm not a fan of at all. It's maybe not great for the liver, and even in terms of levels, it's just not consistent.
Yeah, that's yeah. And would you find that, is it creams or injections that, because I know people that are on all three, as you know, as you start to talk about it, your friends will be like, oh, I'm doing the cream, and other friends are like, oh, I do the injection. The injection's an IM, right? Intramuscular injection.
It can be IM or it can be sub-Q, just under the skin.
And is that a weekly or is that a daily?
Yeah, so that's where it gets interesting with injections, is because, you know, there are some offices out there that would have you inject once every 2 weeks, and then ones that do once every week. To get consistent levels, it should be done at least 3 times a week, and you can make the case for daily or every other day.
Yeah, because, you know, as your body metabolizes that, again, you talked about free testosterone, and when you look at that in your blood work, there's total testosterone and free testosterone. Total testosterone is what's bound, not available for use. Free testosterone is what's available for the body to use. Yeah, I mean, and I love how you called it that sine wave, because we're going to utilize that testosterone, the free testosterone, and then we need to replenish it, because in the males, our testes are what is in charge of creating testosterone, not functioning as well as before. Is that? I mean, I know there's some other things that are driving that process as a hormonal situation, but working on the downstream effect. So I guess the cream would be easier to do daily. What are the difficulties with using the cream in your patient population? What do they tell you that they like and don't like about it?
Yeah, so the cream it's all about consistency, because if you go out of town for the weekend, you forget your cream, your levels are going to tank. So you know, most cream protocols are actually probably twice a day, or, you know, at a minimum once a day. And then application of the cream is the other thing that a lot of times with the patients, they don't get right. They don't get it rubbed in enough, or they rub it in the wrong place. And so that becomes challenging. And so they don't get great results because they're not actually using the cream the proper way. But cream used properly and consistently provides excellent levels and excellent results.
And then the injections, at least you would say probably once a day. And I know this is going to vary from patient to patient, level to level, provider to provider. Injections, you'd think probably be a once a day kind of a thing.
Ideally, it would be once a day.
Yeah.
In all the studies that show benefits of testosterone, nobody in those studies got an estrogen blocker, whether that would be DIM or whether that would be anastrozole or what's called an aromatase inhibitor. Because much of the benefit of testosterone actually comes from the metabolite of estrogen. And so DIM, aromatase inhibitors, are not helpful and actually dangerous in many cases.
So good, because we're on the same page as far as that goes. Okay, so I'm going to switch gears a little bit. I don't know if this is your specialty, but of course, you know, we're talking about men's health. How is this? I want to switch over to erectile dysfunction, because this could be the reason men would seek testosterone supplementation. They feel like they're not doing as well in the bedroom. But I do know that, you know, through the course of a night, right, as we sleep, we're supposed to have a number of erections. And generally speaking, Most men wake with an erection in the morning, at least at some form. And then as we get older, we realize that's not happening as much. There's certainly a lot of medical conditions that can be in the background on that. What would be the things if somebody comes to you and says, Doc, I think I have low T because I'm having some erectile dysfunction issues? What are you going to be looking at? What are the things that you want to say, okay, well, let's screen out these issues before we jump into maybe just straight testosterone?
Sure. Yeah. So definitely, blood pressure plays a role. If you're insulin resistant or have metabolic syndrome, that means your vessels are not working as well as they should work. And an erection is about vascular flow. So I'm looking for underlying metabolic reasons that they would have trouble with getting or maintaining an erection before I jumped to testosterone as being the answer. And then there's also there's situational and relational things to think about. Sometimes the difficulty in performance has to do with the relationship itself and has nothing to do with anything physical.
What are some of the options for, this may or not be your specialty because I know there are some clinics who specialize specifically in this. What would be some treatments for ED that you might explore with your patients?
So it's one of those things where you kind of start with, benign basic interventions and then you escalate as needed. So certainly optimizing testosterone is going to be a step in that. Nitrous oxide, incredibly important. As we age, our nitrous oxide production declines. And so nitrous oxide supplements can be very, very beneficial. And then, medications like Cialis or Viagra would be kind of next line, whether that's like a low dose daily Cialis or a higher dose Cialis or Viagra prior to intercourse is kind of next step in line. There is shockwave therapy, which has kind of come on the scene in the last several years and been shown to be very, very effective. The idea behind that is, again, it's a vascular issue. If you have plaques and lack of blood flow, that's going to cause a difficulty with erection. Shockwave therapy is essentially ultrasound that breaks up those plaques and improves flow. And that can be a series of 6 to 12 treatments, over a span of a few weeks, and gets very, 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 very good results. And then you can kind of escalate from there to PRP treatments. There is also Trimix, which is another kind of injection that you would do kind of right prior to intercourse. So is an escalation of interventions.
Well, I like that. And I think if we're going to talk about that side, generally speaking, most like erectile dysfunction, all erectile dysfunction, honestly, I think it boils down into two camps, right? A blood flow issue, being one, usually a vessel issue on the way in, and then blood flow leaking out, the inability to maintain the erection. How there's a couple other things that I want to talk about because I know that you're kind of a fan of these. What are some natural ways that we can help because we have exogenous, means coming from outside of our body, exogenous testosterone supplementation. How can we just naturally increase testosterone in our bodies? One of the things that I've been working with is daily cold plunge and exercise. So those two types of things, I pair those together. There's some research on the order of those. It wouldn't be the order that I would like, but what else? What are your feelings about those two things? I know exercise is easy, but what are your feelings about those two things for sort of increasing our overall resting hormone or resting testosterone level in men?
Yeah, I'm a big fan of both of those. Certainly, exercise is particularly related to strength training for sure. Is can definitely be beneficial. I'm a huge fan of cold plunging. I cold plunge every single morning. I was in it at 5:45 this morning, so I'm completely addicted to it for all the benefits. But yeah, those types of interventions can definitely move the needle for sure. And along with, again, good sleep, managing your stress, good nutrition. If you have any, insulin resistance and that sort of thing, addressing those issues and improving those issues are all going to help your underlying production or endogenous production of testosterone. The question always becomes, is it going to be enough? Is it is it going to move the needle enough to where you actually have symptom improvement?
Yeah, and I think that's really the key. I don't know that you can cold plunge your way up to the numbers that you need in order to feel better. But for me and for some others, I feel that it's just a part of overall good health. I love the cold plunge. I love the mental toughness that it gives me. I love the peace that it gives me, and I love to be able to kind of create that situation for me. For the women, if you're listening, cold plunge has an amazing benefit. I think they've done some just one-off studies with salivary testosterone in women, and they cold plunge and they almost get a 2x increase in salivary testosterone in women. So there's some theories about how that works based on men. Maybe it doesn't work as well because our testes are external versus their ovaries, and their testosterone building system are internal, but they tend to do really, really well. So for women, if you're looking for a little bit of a boost before or after your exercise, cold plunge is a great way to go. So Alan, what am I missing? What am I missing about this conversation that we need before we wrap up? And then I do want to make sure that we give our listeners an opportunity to know where they can find you, your website and your practice location and things like that.
Sure. Yeah. I think that the biggest message I try to get out is wherever you're at in terms of how you feel or your age, like to not give in to, well, I'm just getting older. Like, or it, I guess this is just how it's going to be. That is not true. If there is a safe and effective intervention that can change the quality of your life in a positive way, both in terms of your daily life and your relationships and your workouts and your job, as well as your health, cardiovascular health, mental health, that sort of thing, then you should explore those options. And that goes along with the concept that, normal is not optimal. And healthcare today, when you go to your doctor and they test your testosterone and he tells you it's normal isn't optimal. And what we're looking for, or what we should be looking for in all areas of life, is what is optimal. What would happen if I got myself to optimal levels? In other words, it's the same with blood sugar. You can have a blood sugar of 100, and that's normal. They're not going to call you a diabetic. It's certainly not optimal. You'd be much better off with a fasting blood sugar of 80. And so that's just a way to think about your overall health, but certainly as it pertains to hormones.
And I love that. And so often I remember that it's often heard that people hear the first and the last thing that you said. And so here's the thing: testosterone supplementation is safe. There's no set number for any one person. It's about how you feel and your symptoms. You shouldn't be afraid to find somebody who's going to help you find better health and vitality and energy. And remember that if there are other medical things in your life, losing weight, controlling blood sugar, controlling your insulin resistance, let's address those so you can become healthy, happier, and live not just a life where we feel like we're aging our way through it, but a way where we're really just powering through life. Alan, thanks so much for spending your time with us. We really appreciated the knowledge that you've brought on this topic, because as lay people, sometimes we're listening to what social media tells us or the news, and we really need experts to kind of give us some direction and help move us forward. So for our listeners and for anybody who wants to reach out to you, what's the name of your practice, where you're located, and how can they consult with you if they need to?
Yeah, so our easiest way is our website, which is www.biosymmetrywilmington.com. We're located in Wilmington, North Carolina, so that'd be the easiest way to connect for sure.
Awesome. And we're going to make sure to put a link to all of Alan's information in the show notes. Thank you again for spending your time with us. I'm sure we'll have other conversations later. I appreciate it.
Yeah, thank you for having me.
Thank you for joining today's show. We're grateful for you. And if you found value from today's episode, would you please consider leaving us a 5-star review? And if there's someone in your life that you feel that this episode would help, would you kindly share it with them? Be kind to each other this week. Take care of each other. And remember, it's the small and simple things done often that make the biggest impact. Nothing in this podcast should be considered medical advice. Please follow up with your medical provider regarding any and all questions related to your health.